name is Dr. Emeka Ibodike. I'm a consultant gynecologist, and I will be speaking to us today on endometriosis. It's important to note that endometriosis, which is defined as the presence of gland and the tissue of the endometrium outside the confines of the lining of the uterus, that is the womb. So when we ask what is endometrium, endometrium, very important. What is endometrium? Because it's from endometrium that we got endometriosis. So endometrium is the innermost lining of the womb where the baby actually stays, where baby implants. The uterus have essentially 3 layers, and this is the innermost part. Now, for some reason or the other, one can actually have the presence of this endometrial tissue outside the confines of the womb or the uterus, and the ones that occurs will say that there is endometriosis. Now, when we ask the question, who is actually affected? About 10% of women worldwide have endometriosis, and usually between the reproductive age group, according to World Health Organization, defined as age group between 15 to 49 years. Now, endometriosis can actually be seen during menopause, and one might answer, or rather ask the question, why? So, well, the endometriosis, is a disease of theories. There are quite a number of things that are not clear. The cause is unknown, but people have talked about so many things: the issue of metaplasia, possibility of having stem cell theories and retrograde menstruation and what have you. These are all, and I must tell you at this point that these theories conflict themselves. If you want to understand this one, this other one might not be able to explain the other one, and so on. So that is it about endometriosis. All right. So usually we can say that endometriosis can either be mild, or moderate, or severe, and there are also different affectations. A very common one is the one that affects the pelvis. It can also be located to affect the gut, that's the small bowel or the large bowel, or the rectum. It can also affect the brain, the lungs. So many, can be anywhere. And what it usually gives it away that most of the time there is what we call a synchrony in affectation or in presentation. That is, a woman might be having her menses, and at that point she's having a chest pain. So you can see the synchrony because there is shedding of the endometrial tissue or cells. So at that point there will be a synchronization with headaches or even convulsions. But diagnosis in this stage needs what we call a high index of suspicion. All right, so how do I know that I have endometriosis, or how do I know? Very important. So we look at the symptoms and signs of endometriosis. Let's say at this point that a woman might actually have endometriosis, but there won't be any symptom, asymptomatic. For such women, you don't go and start looking out for whether they have endometriosis. However, when they have symptoms, topmost on the list is pain. Pelvic pain, otherwise classified as the chronic pelvic pain, usually when it's more than 6 months, have this debilitating pain in the pelvis. The woman is always having the pain. Sometimes the pain might synchronize with menses, sometimes it doesn't. It runs a course, an indolent course from year in, year out. The woman is just in pain. It can reduce the quality of life. So when such a thing occurs, the woman might possibly be thinking that there is a possibility that she may have endometriosis. Pain during sex, what we call deep dyspareunia, not during insertion. During insertion, when the phallus is entering the vagina of the woman, there might be pain if the woman not necessarily ready for the sex. But we're talking about when during sex itself and the woman is having pain, that we'll call it deep dyspareunia. This is not supposed to be so. Sex is supposed to be pleasurable. But if it's all pain for the woman, one might think there might be possibility for endometriosis. The same thing happens if a woman is seeing her menses and she has pain all through the menses, not just the first 1 or 2 days, which can be physiologic. If the pain is throughout the menses, some of them can be debilitating. She might not be able to go to work or go to school because she's on her menses. She should think critically that she may have an endometriosis. So these are some of the things. Then there can be affectation of the rectum. So if the woman farts, gases, and she will feel pain, might think of possibility of endometriosis. If she's urinating, she feels pain, or having hematuria or blood coming from her urine, that can also suggest that she may have endometriosis. Then I've talked about the issue of having a chest pain or hemoptysis. She coughs out blood during her menses, or she's have convulsion during her menses. These can be pointers of endometriotic disease. Now, what can she do? This is a very important, question. She has to first of all seek the services of a gynecologist, who will take a robust history, ask her a series of questions, then perform an examination, which may or may not, depending on what she presents with, might lead to either vaginal examination, of course, abdominal and systemic examination, and so on. Then after that, the doctor will synchronize it with some of the possible radiological investigation. There might be an ultrasound, MRI, or laparoscopy, as the case may be, to further substantiate the diagnosis of endometriosis. Treatment, that's the tricky one and the difficult one. The treatment might be quite challenging. It can be surgical, it can be medical. Medical treatment, use of drugs, they need to consider 2 things. Is the woman trying to get pregnant in recent times, or is she just concerned about her pain? So most of the time, the medication used for this pain might militate against pregnancy. So it's important to first of all have these questions forward, put it forward, and get it straight on. Then, of course, the doctors will now use the range of medications for the pain, when pain is the main issue for the patient, or for the bleeding. Now, sometimes I need to mention that endometriosis can also cause abdominal uterine bleeding, and if that occurs, of course, that will be treated as such. But once a woman is having abdominal uterine bleeding, it will not necessarily be uterine fibroids. So if it's not uterine fibroid, you have checked bleeding, problems is not there, you might think of endometriosis, because that can also lead to abdominal uterine bleeding. So by and large, endometriosis can also cause infertility. Now, the infertility cause for endometriosis are divided into 2 arms. The first arm is where a patient has mild endometriosis, that is what they call endometriosis, or just little symptom, little affectation of the tissue, but the woman is just not getting pregnant. So she can be classified under infertility that is actually that you don't have any reason why the woman is not getting pregnant. But when there is dense adhesion, she has endometriomas affecting the ovaries, she might have problems with ovulation, problem with ovarian pickup, with the tubes affected. Those can also might need special attention. But what is important is that endometriosis may be recurrent. Even when the endometriosis is treated surgically by what we call use laparoscopy to burn out some of the tissues, it might recur and the woman might have symptoms. In fact, sometimes the treatment might be recurrent treatment. You treat the woman, next time she comes again, you treat her, she comes again, until she gets pregnant. I said that sometimes we believed in the past that pregnancy can actually ameliorate the symptoms of endometriosis, but it's not usually the case. It may also continue even with pregnancy. Let us summarize by saying that endometriosis is real, it's with us in this world. The last conference we went in Paris, we were talking about the issue of the current thinking as regards the pathway of endometriosis. One of the most complex pathways everybody in that hall has seen, and we just started laughing because we don't even know where to start from. That is how complex it is. It's a serious challenge for every health practitioner, but we believe that with current thinking, with current research, we will be able to find a better way to treat endometriosis. Thank you very much. I remain Dr. Emeka, the gynecologist.